Peace. No, we're good on that. Everybody's got that. And also, members, in your packet, David Zach, who is our new committee administrator, because Kevin Parker, who was our committee administrator, got poached from us. Can I use that term? To a good thing. He is now the policy advisor to the governor on human services, housing, and homelessness. And so with that, David Zach is now our committee administrator, and Cassie Soar, to the left of me, is our new legislative assistant who was house trained. She was over in the House last year, and so she moved up in the world. Thank you, Senator Rasmussen. You are also house trained as well, right? Oh my God, and so are you, and you. Anybody else? Senator Abler? Utke, I think you and I and Omar and Senator Mitchell and Senator Matthews are the only ones not house trained on this committee. Can I say that? That's pretty funny, isn't it? So anyway, thank you for laughing. My wife was right. I'm not funny. Don't try to be funny. But Cassie is joining us as well as the new legislative administrator, legislative assistant for us here as well. And then members, there's new pages that we have assigned to our committee, and pages that John Bridges, who I met, Spencer Olson, and Luke Seck is here as well. And so just wanted to highlight that to you as well. So our call to order, as we look at that, you know, this first day of session, I really wanted us to focus on our priorities, which we'll get to. And as you'll see in your folders, David Zach put together some bills that y'all were authors on last year, and bills that we had within our both our policy and our finance omnibus. And so there's those sitting in front of you, member by member. But then I also wanted to have just our whole conversation about, look, we got 43 days, right? What it is that we need to get done. How can we focus as a group? And specifically highlighting, I don't know if you saw this, but you know, majority of the middle, I guess, was tracking the most bipartisan work in the state, and we were number one. We didn't get the most money, but we were number one, so I was pretty proud of that. And I want to keep highlighting that, and clearly it's what Jim Ramstad taught me years ago. It's not about partisan politics when it comes to human services. It's really about getting to what's important in front of us. So with that, I got Elise Bailey and Matt Burdick. Welcome back to give us a wonderful budget update from the Department of Human Services. Looks like Nicole is with you as well. No, you're...
She's my care attendant.
I love that.
Thank you.
Are you an SEIU member, by the way? Because that's, you know...
Talk to Rick.
You want to talk to Rick Varco about becoming a... You got a card? That's good. I love that.
Good to know.
Are you set for that now, Miss Bailey?
I am.
Welcome. Nice to see you.
Thank you. Nice to see you.
What do you got to share with us about the state of affairs? And you know, I would hope that I don't get to say what I said last year 100 million times. I don't know. Senator Mayquade, how much money was left on that out of the reserve?
Mr. Chair, I believe it is $1.82 billion.
I think that's right. Isn't that right? You know, that was always the thing we were talking about. But
sounds about right.
That's right. It came out of here. So anyway, welcome to the committee. Just go ahead and state your name and just for the record. So thank you.
Sure. Thank you, Chair Hoffman and members of the committee. I'm Elise Bailey. I'm the budget director for the Department of Human Services. Very honored to be with you today, especially on the first day of session. I'm hoping to go over today where our budget stands at the Department of Human Services and to talk a little bit about what passed last session and where we're at on implementing the really important items you all put into law. How do I put the PowerPoint up? There we go. Yeah, so again, I'll be going over the budget, a few points about what we saw in the November 2023 forecast. Of course, we're closely approaching the February forecast, so I won't go too far into the weeds there, but I'll note some key things that we're seeing. And then again, some really important legislation you all passed last year. So as budget director of DHS, I really like to center any presentation we do around what's most important, right? The people that we serve and the people that rely on the services of DHS. So this slide just kind of gives a brief snapshot based on the November forecast on how, what the average monthly recipient count for each of the key kind of slices of our data that we have. 1.4 million monthly Medicaid enrollees, just over 100,000 Minnesota Care folks receiving healthcare through Minnesota Care program. About 12,000 people across the state receiving long-term care in our nursing facilities, and 86,000 receiving long-term care services in their homes and communities. This committee has jurisdiction over the Behavioral Health Fund, which funds substance use disorder services. So we have about 31,000 annual unduplicated folks in the last year who've received services through that resource. We have about 883,000 families, enrollees on the Families with Children section of MA. And then 22,000 people receiving GA, general assistance, and 20,000 folks receiving housing support. So the decisions you make in this committee are certainly monumental in people's lives. So looking at our all funds enacted budget across the state, across all agencies, it's just good to get a big picture of where we sit in relation with the rest of state government. So the Health and Human Services bill area, this includes not just DHS, but also MDH and the boards and a few other smaller entities. But we take about 43% of the all funds budget. So this is not only the general fund, but Healthcare Access Fund, federal funds, all funds basically, with early ed through 12 education taking about 21%. The next slide goes over the general fund budget. So those two bars are flipped. So you'll see DHS gets a lot of federal funding, which is why we take a smaller proportion of the state general fund budget, but still at about 30% of the total general fund budget. The budget that was enacted in last session for 24-25 across the state through the general fund was about $56 billion across all state agencies. So we took up about 30% of that. Digging a little bit deeper into DHS, so as I kind of mentioned, we get a lot of federal funds. About 56% of our budget is from the federal government, with 37% from the general fund. The Healthcare Access Fund funds some Medicaid and Minnesota Care expenses, about 4% of our budget. And then special revenue and opioid epidemic response account, funding some key SUD-related investments. This slide just kind of goes over the expenditure trends over time. What was passed into law last session certainly gave quite a big bump in DHS's total expenditures. So you'll see the difference between 23 and 24, a bit steeper than you'd see in previous years. So you'll see the general fund going up, but typically when we get a lot of funding from the state through the general fund, we also have federal matching dollars. So you'll typically see a matching amount applied. And then this slide just kind of goes over our budget as a whole and where the funds are spent. So about 69% of our budget is spent on MA, medical assistance. We also have other forecasted programs, and here we have the Child Care Assistance Program, Minnesota Family Investment Program, some smaller forecasted programs. That's about 8% of our budget. We do have quite a bit of grant programs at the department, funded both through state and federal dollars, and those account for 12%. Direct care and treatment, about 2% of our budget. And direct care and treatment, of course, I'll go into this later, but they're shifting off to be their own state agency, so that amount of our budget will will shortly be shifting over. And then operations is about 3% of our budget. So this is systems work, this is FTEs, this is all the folks employed at DHS to do all of the work that's required to get the programs off the ground and administered at the state. This slide I won't go into detail, but it just kind of breaks out the budget in fiscal 2024. And I kind of pulled out different grants that your committee would have jurisdiction over. And these are all dollars, so some of those are federal grant dollars in there. So I'm going to delve into the forecasted programs, specifically medical assistance. So some key things we found in the November forecast. Our forecast was up. We had almost $1 billion higher projections than the previous forecast. For the majority of that increased spending was increasing trends we're seeing in the home and community-based services under the disability waivers. So we're seeing increased higher payments and increased number of people over time receiving services in their home and community through those programs. The November forecast also included changes in enrollment estimates based on the unwinding process. So during the COVID pandemic, we were required by the federal government to keep folks on the programs in order to ensure that they had access to health care. But now that that federal pandemic has ended, or the federal emergency has ended, we are now returning to normal eligibility processes. And so each forecast, we're updating the enrollment estimates based on what we know as that process has been implemented. And then lastly, one of the big key takeaways from the November forecast is we have a federal funding formula that calculates how much the feds will kick in towards our Minnesota Care program. And that formula is pretty complex, but they changed one factor in it that essentially reduced the federal funding that we receive through that program, increasing the costs that the state then has to pay for Minnesota Care.
Mr. Chair,
Yes.
do you want
Senator
do you
Abler.
want questions now or at the end?
You know, do you want to
I don't care either
do,
way. It's up
you're
to you.
good? Let's just have the conversation. So, yeah, Senator Abler.
Well, it's just an easy one. Thank you, Mr. Chair. Yeah, nice to see you all again. Welcome back, everybody. The Healthcare Access Fund, usually you don't take that up as part of your normal discussions. It's an MMB thing, but is there an updated chart that we can get about that?
Ms. Bailey?
Chair Hoffman, Senator Abler, I can gather that for you. They should have an updated fund balance for that program after November, and probably a new one after the February forecast comes out.
Right, and so, Mr.
Senator
Chair,
Abler.
it's like, when you say it's going to increase cost, it was already running pretty dry, so I'd be interested to
Ms. Bailey.
see how desert-like it is. So thank you very much.
So, interesting, because that's something that has been utilized for access in the past, right, Senator Abler?
Mr. Chair, it's been used for many things in the past. And there was quite a bit of funding in the fourth year of the biennium taken out of there to support any array of programs.
Okay.
So I was concerned it might not be sustainable. And
That'd be nice to see that report, if that would be, thank you, Ms. Bailey. Thank you, Senator Abler. Ms. Bailey?
Yep. So slide 12, this slide just goes over the MA enrollment that we've seen over the last several years. As you can see, it peaked, as I mentioned, during the pandemic, and now we're undergoing the unwinding process where we're re-enrolling folks based on eligibility. This slide breaks up the Medicaid program into three basic eligibility categories we have. One is children and families, the next is adults without kids, and the third is folks with disabilities and older adults. As you see in the chart, we have a large proportion of the program sits in the children with families segment of enrollment. And a smaller proportion sits in the segment of people with disabilities and older adults. The pie chart to the, the right shows the total expenditures and the percentage of expenditures within that same category. So logical explanation where you have a smaller segment of folks under the people with disabilities and older adults category, but their cost of care is exceedingly higher than the other segments of the Medicaid population. I would also note that these populations have different federal matching dollars. So while the adults without kids takes up 24% of the total expenditures through state and federal dollars, they have a very high federal matching percentage. So the actual state expenditures are pretty low.
So Ms. Bailey, out of that children and families, has there rolling out the children and youth new thingy, I think it's children and youth services, or the new piece that was passed last year, is there going to be an impact on the Medicaid, as a Medicaid agency? Is there going to be some of that rolling into that new department at all? Do you know if that's a fiscally, I mean, if you're looking at a percentage of 20%, there's got to be some amount that would probably do that. Is that something that's your window that you're aware of?
Chair Hoffman, so we are developing the Department of Children, Youth, and Families, DCYF, and no, the Medicaid program in its entirety will stay at DHS. So all the expenditures around the program would still be administered by DHS. We are ensuring, though, however, that there is that we're crossing silos when we're creating this new department, particularly around kids with disabilities and kids who experience behavioral health challenges, that we're aligning our departments and we don't kind of lose what we have now, which is a synergy among one agency.
So thank you for that. In the birth to three world, there's a discussion of payer of first resort, payer of last resort. And Senator Ahlorn, we're going to quote 99-457, comprehensive, coordinated, and collaborative. That's what the feds said the early intervention services must be, right? And so as they're looking at that conversation, I'll be watching for that. Are they having that? Because when you start to get into that Medicaid, so who's the payer of first resort, who's the payer of last resort? That was a national conversation, started in 1986. So thank you for that update, and I thank you. Keep going.
All right, slide 14 goes over the average monthly costs per enrollee in the Medicaid program by those different categories, but I've broken it out a little bit more where the red line is the long-term care facilities. So this is the majority of this line are folks receiving care in nursing homes, and where the trend line on the average per monthly cost is a bit steeper than you'll see in other areas of the forecast. The next steepest is the home and community-based waivers and home care, and I'll get to that in a few slides here, but this just shows on one slide how quickly the different populations are growing over time.
Senator Makewaid.
Yeah.
Thank you, Mr. Chair. And at least in the slide number 14 that we're on, part of my question was answered by looking at slide 15. But I remember there's like 11,000 people who are in nursing homes in Minnesota. Is that about right?
About 12. Yeah. 12,000.
12,000? Sure. Thank you, Mr. Chair. And then if we're looking at the number of people who are in waivers and home care, do you have, on that line graph, do you have the exact number, 12,000 and the green line? Yeah.
Chair Hoffman, Senator Makewaid, 86,000.
Thank you. That's it.
Thank you. Ms. Bailey.
All right, this slide we've presented to you before, and it's really a good depiction of our long-term care service continuum and where we've come from and where we're really headed. The green line indicates people who are choosing to receive care in their home and in their communities, whereas the blue line depicts the number of people receiving care in long-term care facilities. And we're just seeing these trends grow over time, where I believe now we're at about 90% of the population receiving care in their home and facilities. I mean, home and communities.
So if I look at that, wow, that's actually gone up last year, I believe. Mm-hmm. The trend line was versus long-term care facilities, it was like 80 or 85%. So now you're at 90%, and then home and community-based setting, correct?
Chair Hoffman, yes.
That has implications on what the system should look like or going toward, so, all right, thank you. Members, any questions on that? Nope? All right.
And Chair Hoffman, I'd say the next presenter, I know Ms. Cook and Ms. Mers are going to go over to even more detail on those trends. Oh, I think I'm going the wrong way. Okay, slide 16. So this goes into the disability waivers. And, you know, I mentioned that one big takeaway from the November forecast was the trends in the disability waivers were higher than we previously projected. And so you see the curve here where almost all the, you know, the CADI and the DD waiver are growing, and they're growing at a fast pace, you know, for the last 10 years. You'll see what we're finding is in the forecast that we're finding increases in the average payment, in the number of people served. So there's a multitude of reasons why the spending is going up, but the kind of the moral of the story is we're serving more people, and the people that we are serving are receiving more services than they had in the past.
Is that trending aging? Are the services on the aging side of it just because of the fact that for the first time in history we have more people 65 and older than we do in K-12 education? Are you seeing that trending to more elderly population on the service side?
Chair Hoffman, we are seeing more people joining the waiver in their 60s than prior. So we are seeing a higher growth in the number of people signing up for CADI and DD in their 60s versus waiting until once they wait till they're 65, they have to sign up for the elderly waiver.
Yeah.
So we are seeing a growth there. And I think I'm going to go into this in a later.
All right, keep going, sorry.
No, that's okay. It's a really, really good question. But we're also seeing growth in younger population as well. So this slide 17 it shows the elderly waiver forecast trend. So you'll see it was relatively flat or maybe going up just slightly each year over time, but the investments you made last session really made an impact in the amount of spending we'll do on this program just because of the rate increases that were badly needed for a long time are showing up here in this graph.
Senator Rasmussen.
Thank you, Mr. Chair. Question for Ms. Bailey. Do you have a rough sense of how much of this is assisted living rate increases versus other?
Ms. Bailey.
Chair Hoffman and Senator Rasmussen, I can get you the exact numbers. I do know that customized living or assisted living services do take up a high proportion of the elderly waiver program in itself, and I think they got about a 40 to 50% rate increase.
That's about right. Thank you. Ms. Senator Abler.
Thanks. Just curious, I ran into somebody who told me an anecdote I didn't quite understand. So in some county-based purchasings, they incorporate their elderly waiver payments into are they capitated on that? And then they just pass it out how they might as though they were kind of a health plan incorporating that service. Is that right?
Ms. Bailey.
Chair Hoffman, Senator Abler, that is correct. If a person is receiving care through a managed care program, their services would be within that capitation payment.
All right, Mr. Chair, just
Senator Abler.
It seems that I think I need to take it offline, but at least one particular county-based purchasing place, which I strongly like them, did not pass the whole rate increase through. And that's something I'd like to talk to you about at some point. So it seems like that's a problem. So our intention was to try to support this niche of the industry. So anyway, thank you.
And Senator Abler, I would assume that what you find from that, is that something that we could definitely have a bearing on trying to fix?
Yeah, they passed half of it on. So the employer gave a wage increase based upon thinking they're getting all the money. So like, oh, anyway, so.
All right,
I
thank
don't
you.
have enough facts to take it here. I just wanted to raise the issue and we'll talk about it. And because I think that, would this committee or the other committee set policy about how that would be incorporated? It'd probably be shared.
Ms. Bailey?
Chair Hoffman, Senator Abler, I'm not really sure about the jurisdictional issue. I mean, you do have jurisdiction over the spending over those programs,
Yeah,
so.
okay, thanks. I know we have lots to talk about.
But
Thank you.
happy to talk further about it.
Oh, for sure.
Yeah,
Thank you.
definitely.
Oh, good point. Ms. Bailey?
All right, so slide 18, this just kind of goes over in general, some general factors that impact spending trends in these programs. So of course, the number of people served, and we are seeing growth in folks served. Many years ago, we had caps on the programs, and luckily now we don't, that when people need services, they get them in the state of Minnesota, and that's a good thing. We also are seeing changes in who is being served. Once those caps were lifted, we're finding that younger kids are joining, or are receiving services through the waiver, and older folks than in the existing population. We are finding also that folks that are new to the programs are more diverse than the existing program. Oh, yes.
Senator, I got two. I got you, or are we going to Mayquaid? Senator Omar?
Senator McQuinn might have asked the same thing I am, but what are some of the reasons you're seeing? Thank you, Mr. Chair.
Thank you. Senator Fate.
What are some of the reasons you're seeing in the growth in the younger populations for this?
Ms. Bailey?
Chair Hoffman, Senator Chate. I don't know if I have off the top of my head reasons, but I can certainly get, an answer for you at a later date.
Senator Fate, follow-up? You're good? Senator Mayquaid?
Thank you, Mr. Chair. When you say diverse, do you mean racially diverse, or is diverse needs, or?
Ms. Bailey?
Chair Hoffman, Senator Mayquaid, I do mean racially diverse, yes.
Thank you.
All right, Ms. Bailey?
Another lever in impacting spending trends in these programs is the volume of services delivered. So we are seeing both, with the waivers, we have, of course, the counties and the lead agencies, the counties and tribes, authorizing services on behalf of folks, and then the providers bill for the services. So in our analysis around the spending trends, we're finding that there's both an increase in the number of services authorized for people receiving care under the waivers, as well as a growth in the number of services being billed. So that's certainly a factor. Also, changes in the availability of services and how people want to receive care. As you saw in the earlier graph, people are choosing different choices in how they receive care in the community than they had a decade ago, and that certainly impacts how much we're spending on the program. And then, of course, payments, so growth in service rates paid to providers. Many of the services under these programs have inflationary adjustments to adequately pay providers and direct care staff for the growth, in the economy over time, and that shows up in our forecasts, of course. And then changes in the billable service units, so some levers that the legislature may or may not take now or in the past, changing a daily unit to a 15 unit and having providers bill different ways. Those are different mechanisms that impact how much we pay on these programs. All right, maybe I'll pause there. I'm next going to jump into some new things we're doing. Okay. So, wow. Last year was an amazing year across all bills. DHS had additional funding of about $3 billion. That was about a 6% increase to our budget. And you, in particular, your bill was $1.35 billion in the first biennium and $1.56 in the second. Now it's our job to kind of get those into gear and make them real. There's complex dynamics for implementation, of course, where one, DHS is transforming into 3 separate state agencies, so a lot of our work is centering around how to do that well and making sure that the state has 3 really well-functioning agencies. So that's taking a lot of staff time and for good reason, being intentional about those projects. Some other complexities, many provisions last year, while they were great, were funded with one-time funding. And so when we're administering those programs, we have to really be strategic about, how we roll out those dollars, how to make them stretch through the carry forward period that the legislature set out. How do we hire staff with temporary funding? So those are some challenges that DHS has been working through the last 6 months. Many of the provisions have similar effective dates, right? We all wanted to get it all done right away. And so we had to take everything that passed and try to implement them all essentially in the same timeline, which is sometimes challenging when you have IT systems that need to be updated, and all the updates can't occur at the same time, for instance, or when you only have the same availability of staff while you're hiring new people, you have to get going on those things. Many also require federal approval processes or grant requirement processes. So the federal approval processes include, putting things on the Federal Register and putting things out for public comment and having that public comment last a certain amount of time, and then putting it into a state plan or waiver plan amendment. And so we have to be strategic about how we would package those things to make sure we could implement them on time. Grants are even more challenging because it requires staff time, and there's requirements that we have to abide by in order to get the funding out the door. So you'll see in a few slides that we're still working on quite a bit of the grants that were appropriated to us last session. And then, of course, we're not immune to the tight labor market at DHS. And so while we're hiring the FTEs that thankfully you all appropriated to us, sometimes that we're finding some delays just like everyone else. So I'll go over kind of big bucket changes that you all passed into law. This slide is great. These are the rate increases, the really impactful rate increases that you passed into law. All of these items have been implemented at this point. So we've gotten federal approval for all of them that we needed to get federal approval for and have implemented them at this point.
Well, thanks. And I remember a lot of these. I know in the home care nursing, I know the Senate had a more robust package. At least that's a good start. But there's having a hard time getting home care nurses, as you well know, even with that. Did we do a home care rate increase as well? I know we had something in our bill. I can't find it. I was just looking for this spreadsheet. No, just the home care, not nursing, just the home care people. Do you remember?
Yeah, Chair Hoffman, Senator Abler, I believe those fell into that other HCBS services bucket. So those ones got the 14.99.
Okay. Yeah, thank you. I'll talk about that later. Appreciate it. Thanks.
And interesting, you bring up the home care nursing one at 25%. I was just one of the pediatric providers. First time ever, they were onboarding 9 brand new nurses, and they clearly going to help with the decompression of the children, youth, in the hospitals that need to come home but need some of that acute care. And I was, and that's specifically the work that we had done last year as this committee that, made a difference in some kiddos' lives. And I was just like, wanted to share that 25% that we did was absolutely huge. Well needed, long overdue, but huge. Ms. Bailey.
Thanks for sharing that, Chair. That's awesome to hear. So this next slide goes over some more complex service and premium changes that you all passed into law. And in the blue are things we've implemented. And in the teal are things we're in the process of implementing. So we've implemented the increasing paid hours, the elimination of the TEFRA fees, and elimination of the asset limits for MAPD. And so we're working on establishing that hospice respite benefit. That was, I think, something you heard in your committee for many years. The PCA driving component. We have a whole project around grants supporting employment for people with disabilities and increasing the availability of shared services under the waivers. All right, and when some of these, when I say they're in process, it means they really are in process where we've done some things, but we haven't completed it yet. So in this category of changes, I kind of bucketed these into like enhancing the whole system, making it work better for people, making it work better for providers, and kind of thinking big ongoing. So you've got some things in here such as presumptive eligibility study or the Acute Care Transitions Advisory Council. We're really brainstorming ways to transform the system ongoing. And so with those items, you'll see probably us come back at a later time with different solutions than hopefully we've had in the past. We also have huge projects here where we're hiring HCBS licensors. I believe we've hired 34 as of yesterday out of the bucket that we got appropriated for, but still ongoing. We have the 48-hour rule task force we're still working on. Of course, DCT is a new agency. And then some huge grants, those Workforce Incentive Fund grants that will go to direct care workers, beefing up the vulnerable adult system, and then providing new grants to new Americans and providers to build capacity across the state. You, of course, had many things in the SUD area of our agency. Two big things that we've implemented are requiring naloxone on site for every SUD treatment facility, schools, publicly funded housing programs, and jails. You also had in your bill modifying the opioid epidemic response council membership, so that added a seat, and made some funding changes around the grants provided to tribes. We're working on a bunch of other stuff in this space, such as a medical assistance demonstration waiver study, where we'll be looking at how to provide MA for people entering and exiting the jail system. The safe recovery sites and harm reduction grants, looking at investing in family treatment startup and capacity grants, implementing the overdose surge alert and a public awareness campaign, so really assisting with the information available to folks across the state around fentanyl and overdose. The opioid treatment program rate methodology, so this isn't effective this year yet, but we're working on that. And then enhancing quality in the SUD space, so implementing the ASAM standards and ensuring that folks have direct access to treatment facilities.
Thank you. I know that, and that leads into the work that we had done. It's nice to see that boxed like that, you know, the sober home conversation. We also, this committee wanted to get a working group, I say task force, but a working group specific on the recovery side. And I know we're going to have a conversation Wednesday with folks within the substance use, behavioral health regarding some of the latest that is out there. And I'm not going to ask you because you're the finance person, but I just want to make sure that everybody is aware that part of our conversation Wednesday will be addressing some of the things that are sitting out there within the substance use world, specifically in recovery. And you know, what do we need to do? What did we do last year? I mean, creating that working group, you know, did we give the right initiative, which I think we did. It'd be nice to see that working group report and then have that in front of us and have the OIG here as well and have the conversation. So look forward to that. But thank you for putting that in there. And I'm also looking forward to the work that Dave Baker, Representative Dave Baker did, you know, when it was conference committee time. He came over, you know, who would think, you know, speaking of nonpartisan work, right? I mean, he's the subject matter expert sitting with the commissioner, and to hear what the commissioner and Representative Baker did on behalf of the work that we had given them, you know, last year, they almost hit, I want to say, every tribe this summer. I mean, it was clearly within their, you know, wheelhouse to go do that and hear what's going on. So I look forward to getting that update from Baker on Wednesday as well. So thank you for putting this like that.
Thank you, Chair. And then this slide just kind of goes over some investments you made in nursing facilities. I'm not going to go into depth here because the next presenter will do a better job than me on letting you know where we're at on implementing these items.
I just want to go back on you enhanced 1115 waiver conversation in that first bucket, and I know Senator Mann is, and Representative Newer, there's some stuff out there. I'm looking forward to that piece and what's missing. And I do also, I know you don't have any control of it, but, you know, the OPT, when we did the OPT, OT, whatever, outpatient treatment, OPT, you know, when we send in those requests to CMS and just, you know, is that money flowing? I know there's a DWRS one where there's a month that's going to be missed because of that. It's like those things are important for us to understand. What should we or could we be doing differently in order to give the department, you know, a greater heads up on getting that stuff taken care of? But I know, Senator Mann, one of your priorities is that whole 1115 waiver and the department issuing that. So I just wanted to highlight that as we're going to talk priorities in the next 30 minutes or so after Val and Natasha come up, right? So,
Yep.
Thank you. You're amazing. I mean, it's just like, I don't know how you keep those numbers in your head, but that's why you are who you are, so.
Thanks, Chair. All right, that's it. Thank you very much.
Ms. Bailey, any final questions for Ms. Bailey on the budget? Was this helpful, folks, to see what we had done and what we're doing? That was good. Was not? Okay. Let's let the record be shown. The senator from South Minneapolis has said it wasn't. Okay. Thank you, Ms. Bailey. Ms. Mertz and Ms. Cook, you want to give us, I think what do you got, 20 minutes or so, or is that fair, members? Does that give us enough time to really, and this kind of blends in with what, you know, I hope our priority conversation is, and we can keep going, so. Natasha Mertz and Val Cook, welcome to the committee. Just for the record, you want to speak into the microphone, say your names, and
Thank you, Mr. Chair, members of the committee. My name is Natasha Merz, and I am the Assistant Commissioner for Aging and Disability Services at the Department of Human Services. We are happy to be here today on this auspicious first day of session and are here to share more information with all of you and context about nursing facilities in Minnesota, both where consumers are choosing to receive their services, how they're paying for them, data on rates and what we know about wages and trends in that space, and then some implementation updates from the 2023 legislation specific to nursing facilities. And with that, I'll hand it off to Director Cook.
Good afternoon. My name is Valerie Cook. I'm the Division Director for Nursing Facility Rates and Policy, and I will be the one walking through this presentation.
thank you, Ms. Cook. It's your pleasure, and, you know, we're here. Do you want us to wait till the end, Ms. Mertz, Ms. Cook, or are you cool with having a conversation?
Mr. Chair, whatever your preference is, we are good either way.
All right, sounds good. Thank you.
Okay, so, Mr. Chair and members of the committee, so to start us off, this is a slide that you have already seen this afternoon, and so I'm just going to kind of skip over it. There was discussion about the 90% or more in home and community-based services. But this next slide gives us a little bit more detail, I think, about what the consumer choices are that are being made here. So we know that utilization in nursing facilities has declined pretty significantly, but I found what this was interesting, the green line here is the private pay. So private paying consumers are using nursing home 40% fewer days, and the other biggest drop here is Medicare, and so that is dropping to about 37%, almost at the same rate as private pay. And if you'll notice, the top line here is the Medicaid utilization that is dropping, declining at about half the rate of those other payer sources. I think what's happening, particularly in the Medicare, could possibly be there's more of transitions from hospital to home and bypassing the nursing facility altogether, which was, you know, Medicare was a major payer source for that kind of transition period, short stay period that it appears that there's some different patterns that are evolving out of that.
Can you pull your mic? Can you lift that microphone up? There you go.
Oh.
Beautiful. Perfect. Thank you.
I apologize for
No.
that.
It wasn't carrying as well as I thought it should be. So, but any members, interesting to see that trend. Ms. Cook?
Okay, so we're all familiar with value-based reimbursement that was implemented effective in January 1st of 2016. And so what this graph is demonstrating is what's happened to the daily per diem rate under VBR. As you can see, it's quite a rapid increase. In the last 9 years, the rates have nearly doubled. And so you can see the biggest increases occurred, those COVID years when the costs were going up quite significantly. I would say now that we're in the post-COVID years, we're seeing these cost increases and rate increases are a little bit more aligned with what you expect with healthcare inflation. I just want to point out that these are annual increases. In July 1st, 2023 was when that temporary rate increase was provided, and I can talk about that a little bit. But if you were to look at just the costs, the rate increases from 2023 to 2024 without that temporary rate increase bump, it kind of settles into a more like the 4.5% to 5% range. Just on the theme of rates, I just want to mention, as you can recall, there was kind of a lot of chaos during the COVID years. Our entire, cost report filing timelines were kind of upended. The audit schedules were all upended. The rates were late to get published. And as of this year now for the 2024 rates, we are all back on schedule. Everything's back on the normal cycle. And I just wanted to point out that last November 15th, all nursing homes did receive a published rate rather than the estimated rates that we were relying on for the couple prior years to try to help with cash flow and kind of deal with that timeline chaos. So we are back, and that was, that's a really key thing for private paying folks. So they do get some advance notice then, and avoid these retroactive large increases that were kind of concerning to, or not kind of concerning, but very concerning to private pay folks. So that's good news. Just to touch a little bit on the forecast, because there was quite a bit of discussion on the previous presentation about the forecast. But as we know, VBR is primarily a cost-based system. There is a delay between cost increases, when cost increases are incurred and when they're actually reimbursed in new rates. But I did want to just highlight a little more specifically that in the fiscal year 25-26 biennium, there is already built in under the VBR generally expected inflation of $250 million in additional revenue for nursing homes. And then I did touch briefly on that temporary rate increase that went into effect July 1st of 2023 for 18 months. And so 70 million of that forecast, there's another 70 million in the forecast for that temporary rate increase.
Off to the right over here, we got Senator Rasmussen and Senator McQuaid, who, by the way, last year, these two publicly, when it came time at the end of the session where an additional $325 million, I believe, was put on to watch Senator Rasmussen and Senator McQuaid facilitate the conversation was, somebody should have been recording that. That was textbook on how to get to the win on that. And so I just, it's off to you two. I should let you two just run this meeting right now, but it was like, with that, Senator Rasmussen.
Thank you, Mr. Chair, for your kind words. Had a question on the $250 million. How does that compare to the last forecast? If we were to compare the November forecast to last year's forecast, has there been a major increase or decrease in terms of what's projected to go through VBR in rate increases?
Ms. Cook.
Chair Hoffman and Senator Rasmussen, if I understand your question correctly, I think that the forecasted increase that we expected under VBR for 24 and 25 is similar at around a 5% rate.
Thank you, Senator Rasmussen. Anybody else? Ms. Cook. Oh, Senator McQuaid.
Thank you, Mr. Chair. And I apologize, Ms. Cook, if this is not in your wheelhouse or if this was before your time. I want to know a little bit more about what was the reimbursement model before VBR and was enacted in 2015. What has it solved? I understand the problems it's created.
Ms. Cook?
Chair Hoffman and Senator McQuaid, so if we go back to the slide with the rates, you'll see on the October 1st, 2015 rate, which was the last rate that was based on old legislation prior to VBR. And so the 2016 rate, you'll notice it didn't really increase that much because of that lag. So by the time, when we rebase the actual cost, that you see the much more significant rates coming through, the increase coming through, for instance, in 2017 and 2018.
Senator McQuaid.
Thank you, Mr. Chair. And Ms. Cook, so I was trying to wrap my head around this while we were doing the negotiations, and I think I'm still trying to wrap my head around it as well, because when I see increased rates, I'm automatically thinking, okay, more staff are getting paid, better wages, people are having better conditions in nursing homes, and we know that utilization is going down. And so I'm just trying to, maybe in a world in which we do something different, where there's not an 18 to 24-month lag for this money to come back because it's going through all these audits and all, I'm just trying to figure out a better way, and I don't know if that's a question so much as an out loud wonderment, but if you have thoughts on that, I'd love to hear it.
Ms. Cook?
Chair Hoffman, Senator McQuaid, there's a lot of benefits to a cost-based system, but to get to a cost-based system, you're going to have a time lag. I mean, it can't figure out, you got to allow a year of expenses to accrue. You need time for providers to compile that information, submit it to the department to process into new rates. So it's impossible to shorten that piece up. Of course, there are other approaches, I guess, that could be taken, built-in inflation adjustments and some settle-ups. I mean, there are, of course, other options. But the way VBR is currently designed, it's almost, I don't see an option to narrow that window with those sorts of cost-based features built into it.
Senator McQuaid on a follow-up?
Thank you, Mr. Chair. And Ms. Cook, just to be really clear, it's like I like each component of it, right? I like that we're reimbursing for the things that we do. I hate the lag, but I understand that we need the lag, and so I'm always trying to find that third way. Maybe we'll find that third way. Thank you.
That's always that question, right? I mean, you guys started asking that, what does this look like? Senator Utke all of a sudden popped up his finger, and it's like, all right, Senator Utke.
Thank you, Mr. Chair. And as I'm listening to this conversation and the comment about the need for the delay, and it seems logical, and I don't have the data in print with me or even at my desk, but when we were having this big challenge a year ago, I had one of the providers that I know real well, that his business participates in the VBR, and he said, if we could only do it like Iowa, he said, they wouldn't be after us for the rate increases they were last year. He said, by getting their reimbursements timely, for most of our providers, whatever they had sitting out there for their reimbursement, which was a lot of money, they're having to borrow because they burned through their money on hand and their reserves. I don't have the data on what Iowa has, but is that anything you've looked at? Because he came out and, he's very involved in this business, and he said, Iowa's got a program that works.
That was, thank you, that interesting. So, and I know that they also have a separation of the private. There's a segregation of nursing service type stuff, but it's interesting. You brought that up at one point in the conversation because he had both facilities in multiple states. This is somebody. So, Ms. Cook, is there anything that you can give us some information or light on? Please don't say Iowa's better than Minnesota. That's unless you're from Iowa State and your quarterback Purdy was, here's the guy that was, an Iowa kid who, too bad San Francisco lost, by the way. But I was happy because, Taylor Swift's boyfriend won the thing. That was for Utke. So what Senator Utke asked, do you think, is there any information or highlight you can give us on that?
Chair Hoffman and Senator, unfortunately, I do not know the details of Iowa's reimbursement system. As you know, there was a rate study that was funded in last session that's due in early 2025. And part of the instruction for that rate study is to look at, neighboring states and make some comparisons, but I do not have that information available at this point.
Is that something, Senator Ecke, I mean, with that, as we're talking about, going forward, because the question of this VBR and what the two senators to the right of you brought up, it's like, is that, can we get that kind of information? Elise Bailey, is that, yes, okay, she's shaking her head, so you'll follow up. That would be for this ongoing, and Nicole's saying it too, so Senator Abler.
Well, thanks. It's a good discussion, and then, we'll talk about it more, I'm sure, coming up during the session. But, been around a little while, and as nursing homes were always, challenged. But I think that what exacerbated things was COVID, and then suddenly they had lower occupancies, but also wages jumped suddenly like $5 overnight. And I noticed on the chart, if you look from 22 to 23, you see kind of a bump, which is the lag of some of that increased costs. And so maybe COVID just taxed the system so much that that's when the real crisis kind of started. It just occurs to me. But I think if we don't have a delay in there, that there's no incentive to manage your costs at all. So it's a hard thing, but do you think that's right, that COVID just pushed it so far? Which is why we're hearing so much now, and we're losing so many nursing homes. Is that fair, Ms. Cook?
Ms. Cook?
Chair Hoffman, Senator Abler, I was thinking about adding that comment to the point that Senator Utke was making, is that delay, I feel, was exacerbated because of COVID and because the cost increases were so much steeper that there's no doubt that created some cash flow challenges. And you can see that. And that's my point I was making, is we're starting to settle. Those cost increases are not in that 10, 12% range anymore. They're more like a standard inflation that you would see in healthcare settings.
Senator Abler, follow-up, are you good? All right, Ms. Cook, thank you.
Okay, so speaking of workforce and wage increases, this is some information again on what's happened pre-VBR and after VBR. This is a positive story. One of the incentives that was designed into the VBR system was to encourage investment in staff wages and in direct care and care-related costs. And you can see here that there has been a significant increase in direct care salaries. But the thing I want to really point out, to be careful with this data, is that this is not a comparison of hourly wage rates. This is a comparison of what it's costing the provider. So these are not hourly wage rates, these are compensated rates per hour, which means that it includes shift differentials, bumps for second shift, bumps for third shift. It includes overtime. We don't have the data to break down what is the actual hourly wage rate. So it's just one thing I wanted to caution not to misinterpret this data. But you can see there certainly has been an investment in wages over time. And I have some additional data here on the impact on staff, but I'll pause if there's a question.
Seeing none?
Okay. Again, you're seeing here the effect on the staff retention during the COVID years. It was was a pretty significant reduction in staff retention. You can see what's happening there in 2021. And the green bars is showing the expansion of temporary nursing, pool use of nursing, which, I think these are all what we're hearing from the field, is about the staffing challenges and the increase in pool costs. And so, of course, as you are dramatically increasing the use of temporary pools like this, you're going to see a cost increase, because pool staff are typically paid, 1.5 times what employees that are working in the nursing facility are paid.
Wow.
Okay, so with that, I'll just talk a little bit in more detail about how are things going with implementation from the 2023 session. So there was about a $400 million investment. Most of that was one-time funding. The temporary rate add-on of $12.35 per day, that is in effect for 18 months. So that will end at the end of this year in December of 2024. That was effective on July 1st, and that was in fact implemented and paid out. There was a cash lump sum payment program where half of it was to be distributed on August 1st of 2023, and the other half would be on August 1st of 2024. So that first half did go out on time on August 1st. I thought it would, that payment was based on beds, the number of beds, active beds. And so you'll see that the payments to facility ranged from $280,000 to $1.5 million to the largest facility in the state. Moving on to the Workforce Incentive Grant Program, that was $74.5 million appropriation. It allowed to pay nursing facilities that were eligible, meaning they earned under $30 per hour, up to a $3,000 incentive payment. And that funding was all distributed in late September and early October, and I have another slide with a little bit more detail on that. And then I also have another slide on the financially distressed loan program, so I think I'll just move on to the
Go ahead.
next slide. So the Workforce Incentive Payment Program, we received 321 applications from nursing facilities. There were about 14 facilities that did not apply for these grant funds. The total requested was far exceeded what we received for the appropriation at $105 million. So what we needed to do was come up with a formula that we felt most equitably distributed these funds to each nursing facility is what we did. And so the money, like I said, was distributed in October, early November, I guess. And so what that turned out to be is we took the numbers of employees that were listed as eligible from all these facility applications and determined that the maximum, the formula allowed $28.40 per employee listed on the applications. That did not mean that it lowered the amount. They could still earn $3,000 as an incentive. And we also allowed the employer share of taxes, employment taxes, to be used as part of this funding. So we did, even though the program was set up for multiple years, we did distribute the entire appropriation in the first year, so we will not be having additional rounds for the nursing home workforce incentive program.
Wow, that went that fast. Senator Abler.
Well, thank you. And so just a couple questions. The applications, everybody who applied got it? A prorated share of the pot, or was there some criteria that you picked, winners and losers?
Ms. Cook?
Chair Hoffman, Senator Abler, all applicants received the same amount, the $2,840 per employee that was listed. There was no
All right,
competitive criteria.
Thank you. I'm
Senator
happy
Abler?
about that. And Mr. Chair, and so this whole business, Mr. Monahan has attempted to tutor me on the complexities of this. And so is this considered, so the money that they paid as a bonus doesn't go into their cost reporting. This is just an add-on bonus that is exempt from all this VBR business. Is that right?
Chair Hoffman, Senator Abler,
Ms. Cook?
yes, this was the mechanism to make sure that this was one-time funding is that those incentive payments are offset on their cost report. This has been designed so that all the incentive funds need to be spent in the current cost report year before September 30th of 2024. So we're not crossing over cost periods. And so then when those rates are set, these costs will not reappear again. So it's a temporary cost.
Temporary. Senator Abler, follow up?
Yeah, so none of their cost reporting was hurt by this. It's just a bonus to the employee. They get the money and it's neutral on everything. Thank you. I appreciate that. I think I didn't do a bad job, Mr. Monahan, asking that question. Thank you.
Ms. Cook, thank you.
Okay, so I'll talk a little bit more about the nursing facility distress loan program. There was $100 million appropriated for that. This is a far more complex program, something we've not ever done before. What we have done is, this program is designed to help with that cash flow crunch, as that we've been talking about with the delay, and to catch up on if there are working capital loans that are out there and things like that. We did an intent to apply as a first step on this so that we could get some scope of interest. We literally did not have any idea. And if we were going to have, 200 facilities apply for this or 40, makes a big difference in how we operationalize this. So we did, the applications for intent to apply forms came in at the end of January. We received 73 applications for a total of $109 million. So, but I felt like that intent to apply was a very brief form, but it was, briefly responding to how they were going to use the money, what it was for. It was very, very informative for us as we develop the final application to make, to encourage that applicants are, steered in the direction of the intent of the loan program, which is this operating loan, working capital type of thing. So our hope is to have that final loan application published by the end of this month, and then allow some time for providers to complete it, get it in, we can process it, and I hope we can start this disbursement of loan funds in late April, May timeframe. There are things about this loan program that's, like I said, is far more complex. It involves legal review and setting up process for distributing funds, taking back the monthly payments. The program is designed to allow 18 months before the repayment begins. And then they have up to 6 years for repayment on a monthly basis. And so those are just some of the operational things we're still working through, but we're making good progress.
Interesting. 72 or 73 intents? What was it, 73, I think? Is that what you?
Chair Hoffman, 73 application of intent.
Intent. So there was a need, there was a utilized need based upon that is sitting out there for somebody changes their HVAC system, whatever it is, that they, to get a low-interest loan. I mean, that's interesting. I'm
Chair
interested.
Hoffman, I would just
I'm blown away,
add-
actually, to see that many people.
Yeah. I would just add that was a total voluntary thing.
Yeah.
There's no commitment to actually apply from that. You're not prohibited from actually applying if you did not do an
Yep.
intent to apply. So I think that there's probably some, let's just see what it's about, a little bit.
Yeah,
more
I just
about
am blown away that 72 or 73 just said, oh, yeah, that sounds like a great idea. We might need to access that, so, okay, thank you.
Moving on to critical access nursing facilities, this is another program that was reconstituted. We used to have it before VBR. The old version of the CANF program, we call it, it was transitioning isolated rural facilities to a cost-based system. VBR went into place, everybody went to a cost-based system. So the way it was designed no longer worked. And so in the last session that you passed, we changed that to be, again, more focused on that delay. If these facilities are challenged by costs, when costs are incurred until they're actually reimbursed, this helps to fill in that gap. We funded 20 facilities. The range, the highest per day was $40 rate increase. And again, this was effective last July 1st of 2023. Not all of them went into effect at that time because of the interaction with private pay notices. And so there was a kind of a staggered rolling that out, but those increases are in effect through 2025, and we'll be issuing another request for proposal for another round of competitive applications.
Wow.
So what's next on the horizon? Just want to touch on a couple of things that we have put forth a policy proposal that I hope that we have an opportunity to discuss here in this committee. That CMS, the federal government, has published a final rule about transparency and nursing home ownership. And what the federal initiative does is it's getting more disclosure about who is buying nursing homes. It's more about the upfront licensing of the nursing homes. We are also seeking additional transparency about the operations of the nursing facility. And our proposal is asking for disclosure of transactions with related parties, and also to disclose the real property lease and rent amount is something that we don't know very much about. What we're interested in getting at here is that there are always a lot of conversations about the distress, the financially distressed nursing facility industry, and we are asked for information about what is, I can either affirm or push back and say that's not true because we don't have this full picture. We cannot do a good analysis of financial stability or profitability without some of these pieces of information. So this policy proposal is just about gathering information. It doesn't do anything different as to how, that's not already an existing VBR law as to how rates are set. It doesn't have that kind of an impact. This is more about information to give the department a better opportunity to assess financial viability.
So your system right now, that whole transparency, I remember in Elk River and in Coon Rapids, there was issues regarding trying to find the owners of, an assisted living facility that housing would serve. I mean, there was all this. It was multiple. Memory care was in there too. Chris Sears did a whole article on that piece, right? He's no longer in Minnesota, but that's still an issue. Do you plan on, Natasha or Ms. Mercer, is this going to be something the department's going to be bringing a policy? Because we're going to slide into priorities conversation. Is this stuff that we're going to see like now, today? Is there something we need to be doing to act upon this to increase that? I thought we had kind of closed that gap, but it doesn't seem that way. Is that correct?
Chair Hoffman, thanks for that question. So while we await final decisions on the governor's budget, this is a significant policy priority for us to get to the information that Ms. Cook mentioned so that we really can get a fuller financial picture. And we know that the costs related to rent, leases, real estate are a significant factor for any business when trying to figure out what's profitable, what isn't, and things like that. So we do really hope that this policy proposal moves forward, but we're obviously awaiting the announcement of the governor's full budget after the February forecast.
So maybe I know Ms. Cook has another slide to go through to finish her presentation, but that clearly, that we're talking 43 days, unless we want to extend this part-time legislature, right? I mean, it's feeling like it's a priority, but it's the first time I've heard of this, and to me, that is a huge priority, especially when you're trying to find out who's responsible for what. So, all right, maybe you'll stick around. Well, you're going to be with us for the next 43 days anyway, so thank you. Ms. Cook.
And the last thing I'll touch on very quickly, Chair Hoffman, is the other thing that's on the horizon that's kind of a big deal for nursing facilities is that CMS is ending the assessment support for our current case mix payment system, effective October 1st of 2025. And so we have to figure out a new way to pay based on residents' care needs, a new case mix system to pay. And so we've been working on this for a while. We have a contractor in place that's an expert. We did an interim step of adding the optional state assessment that helps us continue to pay under our current case mix system, but we do need to make some sort of a transition. So we are continuing to work on that. We're continuing to model data. We'll be continuing to work with stakeholders, and we'll need to come to the 2025 legislative session with some sort of a transition plan. So just wanted to give a heads up on that.
No, Ms. Cook, is that where we have the EW caddy waiver? Are we, is that included in that piece, that case mix? Or is this a whole different issue?
Chair
aside from
Hoffman, that is not included. This would just be nursing home cases.
Just the nursing homes. Okay, thank you. All right.
And that concludes my presentation.
Members, we're good? It's a good conversation. Thank you for updating us on what's in your world and our world. And it's interesting to see the changes that are occurring in front of us, and to see the need that's out there. Still, the question I think for us to look at is, so why are the nursing homes still struggling? And right, it's a question, right? I mean, that's all it is. It's like, so Senator Rasmussen, is this your equalization conversation? Is it?
Thank you, Mr. Chair. No, I mean, when we look at the overall trends, right, the utilization is going down,
Yeah.
like the total number. The cost is going up.
Yeah.
And I think those are actually the trends that we want to see, because what it means is that we're having higher acuity residents in the long-term care setting. And I think, that those are the trends that we're going to want to see over time, right? Where it's, if you were to look at the population within skilled nursing facilities today and compare it to 20, 30 years ago, they're a sicker population that has higher needs.
Gotcha.
And so I think overall, if we can keep people in their homes longer, keep them in lower acuity settings, lower
Yep.
cost settings, that's, I think, the answer over time. But we shouldn't be surprised when that actual per day rate continues to go up, because the population that is utilizing those skilled nursing facilities have more needs than the population did a decade ago. And I don't know if DHS would have, any comments on that in terms of the overall trends, but that's at least how I think about some of the information we've received today.
And Ms. Merce, I think that, and before we go to Senator May-Quade, but does what he's saying make sense to you too? Is that?
Chair Hoffman, Senator Rasmussen, I think if you compared today's nursing home utilization with several years ago, I think you would be right. In more recent years, we are not seeing that increase in acuity. I do think that what's happening is that assisted living, for instance, memory care is taking care of much higher need people, and you're seeing that consumer transition on consumer choice. But as far as is the average care level in nursing facilities going up, not necessarily. So,
Senator May-Quade?
Oh, thank you, Mr. Chair. And I believe this is something we talked about too when we were doing the negotiations, but there's only you need a certain amount of staff to take care of a building, to prepare food, to do laundry, so regardless of the number of people who are there, there is a certain number of people it takes to run a facility. And I think that's also something we're running into, is there might be fewer patients or fewer clients there, but you still need 4 people to cook all the food or to do all the laundry and what have to clean. I believe that's part of it as well. Am I right?
I see they're shaking their head.
Okay.
They're shaking. I
Chair
looked at,
Hoffman.
yes, Val, go ahead, Ms. Cook.
Senator May-Quade, exactly, you're talking about fixed costs
Right.
that cannot be altered because your census is going down. And so that is contributing to, the fixed costs are primarily in that other operating price that does show significant growth from year to year, which I think is a reflection of that.
Jordan, anybody else? Thank you, you two. Thank you. We still got a lot of work, so that should lead us into this next conversation. Thank you. Yeah, Natasha, maybe, if you're going to be sticking around as we're talking, it's really the conversation about what are our priorities, what's left and how much time we have. And if you can, when the governor's setting it, I know you guys aren't supposed to share with us, but it'd be kind of nice if maybe, there was a mouse in the corner that would, give us an idea, but I won't stress you out on that. But prior to us transitioning, I just want to let us know Wednesday is we're having a joint hearing on Wednesday, right? It's going to be the House policy, the House Finance and Human Services, and really we're going to talk about, the work that we're doing with our RCOs, right? And specifically on the peer recovery side of it. I mean, there's an emphasis there. And I don't know if y'all have, seen the different stories that have been out there. Carol Levin has highlighted some, some things that we should take a look at, especially when it comes to the optics of, what does the oversight have to do? I mean, I think that falls in our jurisdiction, what's missing, what's not there. I know Representative Baker, this is something, subject matter expert. So it's going to be nice to have, I think, we're going to have enough room around here to get both committees in here? Or we do like the House where they put chairs on the other side or something? So, yeah, I'm looking at a former House member over there too. So anyway, just that, we're going to have, Christie's going to talk about policy strengthening. There's going to be some OIG functional conversation. And I know Jeremy Drucker also, because we funded in addition to the addiction, director of addiction services, addiction, or, people are saying the drugs are, I hate that. But it'd be nice to get an update specifically on the fact that Representative Baker, Jeremy Drucker, and the commissioner really did something that has never been done, which was to get out and really have in the street conversation with the people that are needed. And of course, Minnesota's addiction and recovery has not changed in 30 years. We're still getting the same end results, right? And so I think within our 43 days, I'd like to see that happen, and that just falls in line with what we did yesterday. But just to remind people, please be here on Wednesday. I want to, we want to have a robust conversation. It'd be wonderful. So priorities, you guys, in your packets, right? Is there anything anybody want to talk about in light of what we're hearing today or what we know is left hanging? I'd like to, offer folks to open up and have that ongoing conversation. What should we be focused on for the next 43 days, right? I sent an email to you guys a month ago. I just want, everybody's smiling. I won't say who the 3 that responded to me. I'm kidding, but go ahead, Senator McQuaid.
Thank you, Mr. Chair. I'm always ready to go and talk about things in this committee. Leftover for me this year, MAPD. There were some lingering TEFRA fees, possibly. There was some, I know, I'm still digging in to find out where they are. It might come in places for people, for foster parents, potentially. I was pointed towards some, it was given to me in a newspaper article, but I have not found specifically where, so I'm digging into that.
Okay.
And then I've had this brought to me in 2 different ways. One was from a group organized in my district concerned about local zoning ordinances to not allow group homes.
Okay.
Separately, similarly, relatedly, but on a different note, there's a neighborhood in my community where there's a person who lives at a group home who's very dangerous. And the city has asked for help because the response, they don't want it to be police. The appropriate place for the person who is having these behavioral issues is not jail or prison. That's not what the neighbors want either. However, they don't know what else to do. They can't leave their houses when he's there. I think he cycles through a few other places, and they feel really lost, and my city feels lost as well. And I'm not really sure what to tell them either. And so there's a gap there between being able to successfully live in the home he lives in and what would be for a lot of other people criminal behavior that is not, I don't believe, a choice by this person. And so that is something that I privately will talk to you about, but I think it's something that has come up in other places, and the response has been broad and harmful to people who live in group homes, and we don't want to do that. And so targeting the issue we mean to solve.
Well, thank you for that. In that conversation, MAEPD, it was like, and how can we find some more money? Right? Because that was like one of those things. I love that. And you're right in there when you're talking about the group home stuff there. I won't mention the city in the western suburbs in Hennepin County. My daughter's name is Hope. Let's just say it sounds like that. And so, but that gap, right? You got folks living whatever, right? The fact is they're in the community, and the Ombudsman's Office of Mental Health, I mean, all those agencies that had some assurance or that had no idea what was happening, right? And there's a professor at the University of Minnesota who's looking at, some language, as far as, how to include that in there. So that's absolutely spot on the policy side on that. That's great. And so, keep us zoned in, especially on that TEFRA thing. I thought we eliminated that, so awesome. I think that's in our theme. I think there's some other people in there too, so cool. Senator Rasmussen.
Thank you, Mr. Chair. In terms of priorities that I look forward to working on this session, I serve on the Emergency Medical Services Task Force, and there'll be some recommendations coming out of that. Individual members are working on that I think could apply to this committee, especially those surrounding non-emergency medical transportation, which is an important piece of the overall ecosystem when it comes to medical transport. I'm also interested in looking at alternative funding models for long-term care and the continuation of our work this last session as well.
Awesome, thank you. And that NEMT thing, right, we did something, but thank you for doing that. Was there a conversation, and I jokingly said, equalization, but at one point you talked about, is that something that's for the long-term care, or is that something that we should just look at the VBR and the other things ahead of that? Senator Rasmussen.
Thank you, Mr. Chair. I looked at rate equalization pretty closely, and I think it's because it only impacts rooms that have more than one person.
Got it.
And when you see the standard of care that those types of rooms are going away over time, the impact of looking at rate equalization is much smaller than what it would have been 20 years ago.
Interesting, because that was
So
a
I
question
think
you asked that
it's
question
becoming
last
less
year.
and less of an issue.
Yeah. Awesome. Thank you for that. Senator Fateh, you're next.
Yeah, thank you, Mr. Chair. I had a list of like 7 or 8 things, but for time, I'll cut it down to maybe 2 or 3.
No, you're good. I mean, it's a conversation, and it's just like and I know Senator Utke, there's some things that he is
Yeah.
working on too, and he's not here anymore with us, but, I just wanted to let you guys know that I think we're going to have a pretty good policy omnibus bill. So go ahead, Senator Fateh.
Yeah, so the first one is around the small assisted facility relocation.
144G
issue,
stuff?
The one that we were talking about, I
Beautiful.
think, the last couple of
Right.
sessions. Many small providers, especially BIPOC providers, are serving their clients in houses that they're renting, and they're not allowed to relocate or get new licenses because of our
Single-family
law.
home. Yeah.
Exactly, and so when they relocate also, they can't get a new license because of the moratorium. So landlords are taking advantage of that, and we want to make sure that they're able to smoothly transition to a new location without any problems. That'd be the first thing. That's something
Did
that
Noor bring something up on that? Is it?
I think
you
he
guys were talking
has.
about last year?
We talked about the last, I think, 2 or 3 sessions. I've been
Yeah.
working with one on the House side. I remember you, Abler, Utke, the last couple of
Utke,
sessions about
yeah.
it.
Yeah,
Or I
yeah,
like
yeah.
to say the good, the bad, and the Utke.
Yeah, that's where all right, I just tried, honest to God, he did. It was the good, the bad, the Utke conversation, so.
But I know it's something that MDH also has been supportive of as well. So speaking with them.
And so I guess, Natasha, as you're looking at, as you're hearing this conversation, I don't know if you want to join us and say yes or not, but it's fine if you don't. If you can't share, if you're in the code of silence, I guess I get that. We got to change that somehow anyway. So thank you for that, for doing that. And that's part of that is that conversation then on the 144G. That's the Housing with Services, the CRS, ICS conversation.
Yeah, and I
somewhere
want
in
to talk
there?
about the second part
Okay,
also,
yeah.
because I know that we passed grants to help providers transition to CRS.
Yeah.
I know that the applications have not gone out yet, and there's been work around with stakeholders to use some of that money to get allocated to help culturally specific providers with outreach and doing some education, and also helping with compliance and things like that. So I know that there's groups working on that. I know RPMN, for example, we've been working a lot with, and they've been showing up with the stakeholder engagement, and an example of a good group that can do that kind of work. But that's something that we're also hoping to get across the finish line. I'll leave it at that.
Are you going to make sure that you're bipartisan in these good, bad, and the Utke? You're going to make sure that you're. Thank you for
Yes.
that. Elise, you're 11, 15, stuff and anything else that's, what am I missing?
Sure. Thank you, Mr. Chair. So I have several 1115 waiver ideas.
Your
or
mic's like, you know, we almost need a Radio Shack guy in here. Nobody knows, none of these
that
young
not
people know.
working?
No, I don't hear it. Is it? Do you hear it? You hear it through the mic, speak? Oh, sorry. No, now you can. My bad.
Your mom voice.
God.
Okay. So I have some 1115 waivers. The idea, several other states have been doing it. The idea is, you know, how do we use federal dollars to put into the state that will essentially prevent disease progression, right? So thinking of housing and nutrition as things that we could use MA waivers for. The other thing is waivers for substance use disorder for people while they are incarcerated.
Correct. Yes.
What?
No, I was just going with you. That's
Oh,
what I was,
like-
yeah, I was like, yes.
For SUD for people while they're incarcerated, I mean, imagine getting them treatment while they're still incarcerated. So when they get out, they can continue that treatment versus starting over or starting from new, which is extremely difficult when you don't have a system in place, right? So again, just doing things to prevent disease progression and to make people's lives a little bit easier. And lastly, methadone regulations. Right now, our state laws are significantly stricter than federal law, which just changed. And so it makes it harder for people in Minnesota to get the treatment that they need. So just basically conforming our laws to the federal laws to make it easier for people to get treatment. And I think those will likely come through this committee.
Really?
Yeah.
Get the jurisdiction. Don't let the other committee poach any of our stuff. So-
And I'm very excited to hear what the EMS task force has to say.
I am too. Do you want to present that? Is that what you're going to do? No, seriously. All right.
Yeah, because holding people in the ER, when we magically find them a hospital bed, but they can't go because they don't have a ride, is awful.
So that leads to that decompression conversation. Isn't there a task force on decompression that, yes, I got to shake, yes, 2,000 beds in our hospitals that are people that are just boarding still to this day. You guys are all getting the reports on the, you know, people that should be discharged. Did I say that right? And they're not. I know one local one, it's 51 a week that should be getting discharged and they're not able to because there's no place to go. So Senator Mayquay.
Mr. Chair, does this feed into the conversation about presumptive eligibility as well?
Oh my God, yeah.
Okay.
Is that, who's got that? Senator Aylwin, you got that? Did you sign the bill?
Well, there's a bill, someone's working on it. I think Bolden maybe has something about that, or Morrison, one of the two of them.
Okay.
So I think that's really, because the part of the issue is who's going to pay for these
Right.
folks. And so there's a guardianship issue, which
I mean, maybe it's
is a
me.
mess.
I might have that bill.
Is that
really?
a man bill?
Might be.
I think Senator Mann has that bill.
We'll see.
How are we doing on time? That was actually pretty funny.
Mr. Chair.
Mr. Senator Abler.
By the way, nobody knows what Radio Shack is anymore, so. Mr. Chair, so thank you
He
to
does.
Mr. Zach for giving me a list of my old bills. And there actually was one on the last page that I thought would be interesting. It has to do with assisted living. I don't know if I missed that conversation when I was out in the hall, but I know there was a lot of minor things to do on small assisted livings that we wanted to get done. And you already said that.
Yep.
Because it's a big deal.
Yep.
And also
Good.
just want to reiterate home care I don't know what, I mean, there's no money anymore. I wish we could have done a little better on the home care rates from last session with the money that we did have. But I think we just absolutely need to find a way to make sure that's as active as it can be and as many people can go there as possible. I was going to ask Ms. Cook about, there was an uptick in some of the nursing home admissions, and I wonder if that's because home care is less accessible. So that's a big deal. So I hope that we can find a way to all the home care people out there. I mean, that's the core. If you do that, they don't have to go into other places, and that's probably a part of the hospital decompression too, if there's someplace they can go and be cared for. Mercy Hospital has 1/3 of the ER beds that are occupied by people who were eating green Jell-O for far too long.
I watched them personally stitch somebody in the hallway, Senator Abler, and they were utilizing the, you know, I mean, it's just, Mercy's jammed
They
full.
get a cheaper rate for that?
I don't know.
Oh,
It's
just
not
curious.
Yeah, it's just, no, but it's there. Anybody else? How's the weather, Senator Mitchell?
There's a chance for snow on Thursday, and I'm a little excited about that, I'll be honest, because it's been a crazy winter.
Honest to God, she's a meteorologist, so if anybody was seeing how that inside baseball thing, so, all right.
I will say, as you know, have the Child Protection Task Force that I'm chairing, because you sit on it. And although I think a lot of those bills will end up in HHS, I'm sorry.
Here or here?
I think
Yeah, yeah, yeah.
HHS. I think the nexus is that, that we work on is making sure there's enough addiction support services so that families can work their case plans if they have removals and get their children reunited if they have addiction services. And then also, we don't want to remove for poverty reasons or mental health reasons. We want to make sure families can get mental health supports so that they don't end up with children removed for child protection just because they haven't
Nice.
been able to get those supports. So,
And there's going to be, what my assumption is, and I asked this in the committee, you're doing a great job with that, is the intersectionality. I mean, there's people, it broke my heart years ago when a mom didn't know what she was signing, and there was no advocate. She lives with a learning disability, right? Didn't understand. Nobody explained to her what she was signing, and she signed away her 3 kids. She came in front of then Representative Jim, you served with her. You served with her too. She's a county commissioner now. Moran? No, not Helverson. Right here in the Frogtown area. Rena, yeah, thank you. Rena and I were listening to that, and it just absolutely just goes, wow. So it'll be interesting. Any of that system stuff when it comes to the conversation of child protection, specifically, if we want to hear stuff like we have time to do that, right? I mean, it's just something we can actually get it here, but that's fine. Thank you for your work on that. So. Things themed out there, from people who responded. So, I don't know. You think Natasha Mersch, you want to, maybe share? No, don't. You don't have to. But a Minnesota thing, you got to ask 3 times, before you do it. So, is there anything else we're forgetting that we should be, working on? 144G, ICS stuff. Child Task Force. Transportation, right? There's that thing in there. Yeah, what you hear on nursing homes, is this gonna, that was good to have that report, wasn't it? So as you're looking at what needs to be done differently, there's, for example, you have in your backyard, there's an assisted living facility up at 169, which is now, fully developed there up in Zimmerman. But in Zimmerman, and it's like, okay, there's some really good things happening. There's how do you enhance, this electronic side of it, right? So I'm doing some kind of health monitoring, actual health monitoring, by using my TV, right? Things like that. It'd be nice to be able to get some implementation on stuff like that. And I see what's happening up there. So, but yeah, and let's be not real quick, but, the reviser, I don't know, it sounds like they're a few days still behind because, God forbid, we've got 1,000 bills sitting or something out there. So, sounds like a plan for people. Don't forget Wednesday. Gonna be here? And actually, that addiction services stuff, Senator Mitchell, that's something that we should be able to have a conversation on, in there. I see where you're going with that, so. Anybody else? Thank you, everybody, for being here. Thank you, folks, for hanging out on a beautiful day. We are adjourned.